Welcome to the podcast series, Reducing the Risk of Severe Illness for Patients with COVID-19. This podcast is part of a micro-learning library on the testing, diagnosis, and treatment of severe illness for patients with COVID-19. This education is brought to you by the France Foundation and supported by an educational grant from Pfizer. Listen as Drs. Charles Vega, a family medicine practitioner from University of California, Irvine, and John Paul Verderese, an internist from INOVA Fairfax Hospital, discuss potential drug-drug interactions, side effects, and mitigation options for treating COVID-19.
John Paul, thanks very much for speaking with me today. This has been an important issue. It's been very much an evolving issue in terms of treatment of COVID-19. We have some tremendous options that weren't available to us, even 6 months ago. But at the same time, they come with some caveats. And I think it's interesting that the NIH has actually put together guidelines that recommend a preferred regimen of therapies, which is unusual when we think about infectious illness overall. And so the first option that is recommended for outpatient-based treatment of active COVID-19 is ritonavir-boosted nirmatrelvir. And so that's been really become a mainstay of treatment in my practice, and it seems to be fairly effective in terms of improving the risk of severe illness with COVID-19, which is one of our main goals of therapy. But at the same time, it has some caveats as well. Who's it working for? Ritonavir-boosted nirmatrelvir, maybe some special populations in mind that you think should be getting this oral drug?
Sure. Thanks, Chuck. Agree. It's great to have this drug available now. It's oral, can be taken at home. It doesn't require the infrastructure of an infusion clinic. And we really need to leverage its availability at this point in the pandemic. I think the evidence shows that it really is best used for folks who are at high risk of developing severe COVID. And really anybody with a comorbidity, including obesity, coronary disease, chronic kidney disease, or really any other chronic illness, I think really will benefit from taking this medication as soon as possible, as soon as they develop COVID symptoms and also with a positive test.
And we know that list of folks who are considered high risk for chronic illnesses is really long. I always think about just starting with 65 and over, because still over 80% of deaths related to COVID-19 occur in that population, many times with folks with not just they're older, but they have 5 or 6 chronic conditions that put them at risk. But what about some other conditions maybe that have emerged as potential risk factors? Folks with mood disorders, that's a very common issue in my clinical practice. But at the same time, those folks generally aren't as old. You might see it in a otherwise healthy 30-year-old. And what about, I think, a very important group that suffered disproportionately from COVID-19, and that's people of color, particularly Latino or Black adults. Will you give them special reserve for treating them with ritonavir-boosted nirmatrelvir?
Yes, I will. I think absolutely a lot of conditions. Yeah, I forgot to mention age, also immune compromised states, but certainly those other conditions that you wouldn't empirically think confer a higher risk. But certainly I think it oftentimes reflects social determinants of health and other comorbidities that may have not been sort of elucidated for that person yet. So definitely after risk-benefit discussion with a patient that has some of those characteristics, we'll prescribe medication.
Yeah, I feel like we're still underusing this oral agent, which is now more widely available. I think we sort of have an austerity complex since the beginning of the pandemic as providers. And so therefore, we're not necessarily giving the treatment we need to because we're used to having nearly nothing or it wasn't available. And so you have to be very selective. And here we have the drug available in pharmacies. So I've been using it more liberally for my higher risk patients and sticking to those patients, which is, if you look at a typical outpatient practice such as mine, it's certainly most of my patients I see every day. What about other special groups? Renal disease, pregnancy, always big concerns when we're using any type of therapy.
Yes, definitely folks with chronic kidney disease have higher risk, and those folks should be treated. To note, there is a renally dosed version of the medication that can be used for folks with GFR less than 30 and also, at end-stage renal disease. Additionally, it is recommended in pregnancy. Pregnancy itself is a high-risk condition, and we want to get pregnant patients treated as soon as possible. The medication is considered safe in pregnancy and also safe for lactating patients if they contract COVID at that point.
And so we should be using it more often. I think that there are some major groups that have not traditionally been receiving ritonavir boosted nirmatrelvir as often as they should. So that's great to mention those folks just right now. But there's also the big concern regarding drug-drug interactions, and those are significant. The first one I think of is the use of statins. That's one of the most commonly used drugs in my practice. Statins are great. Generally, I think it's worthwhile just to hold the statin for a week while they're taking in a few days after they finish ritonavir boosted nirmatrelvir. But that's not the only drug interaction, unfortunately, when we come to this drug, which is, I should mention that those drug-drug interactions are really driven by ritonavir. And if we are able to come up, and there are some agents in development that won't use older drugs like ritonavir as a boost to promote greater efficacy, and take that out of the equation, probably don't have nearly as many drug-drug interactions.
Right, agree. And that's caused a lot of consternation among providers over the past few months about whether to prescribe or not based on these drug-drug interactions. Definitely statins are most common, which I think, it can be mitigated by holding the medication, as you said, during the duration of treatment and a few days after. A lot of common blood pressure medications are considered to be safe with the medication. In particular, calcium channel blockers at this point, safe with continued monitoring the patient. So if they start developing, symptoms of hypotension or anything, give them guidance at that point. Clearly there's some medications where it's not really great with, such as anticoagulants. I think we've learned that. Of course, if you're on warfarin, just like with any other medication, monitoring and adjusting the dose is recommended. But rivaroxaban does not go well with ritonavir boosted nirmatrelvir, and apixaban. That can be considered not great, but sometimes if you feel safe, reducing the dose for that period of time during treatment, it can be an option. Just want to also mention that if patient has HIV, they should be treated, and it is felt to be safe to continue any of the HIV medications while the patient's being treated for COVID.
Yeah, John, I really appreciate you bringing up the anticoagulant issue, because this has been a real tension in trying to provide a ritonavir boosted nirmatrelvir. And so therefore, that's where I've actually gone very recently, in fact, last week, and had a patient instead use bebtelovimab. And they had multiple medications, so there was multiple drug-drug interactions in the same fairly frail patient, high risk overall. And so I referred them for infusion with a monoclonal antibody that has been shown to be effective against the Omicron variant, which is bebtelovimab. And we do have some other options, so it's worth mentioning those that are not that first-line therapy. Actually, preferred therapy still remdesivir is recommended as an outpatient. And there, it's not so much a serious potential side effect, a serious safety issue with remdesivir. It's more the timing of it with a 3-day daily IV infusion that makes it more of a challenge for my patients. I don't know if you've had similar experiences.
Agree. And at our institution, we made a decision to use bebtelovimab as second line when patients aren't a candidate for ritonavir boosted nirmatrelvir. But certainly there are times when folks have wanted to employ remdesivir. We've chosen to really reserve that for very particular circumstances where patient's very sick or there's a compelling clinical need, because what it does is essentially reduces the capacity of your infusion clinic by a third in terms of who you can treat. So the goal is really to get any one of these medicines into someone as quickly as you can. I think the oral medication has proven successful there, and bebtelovimab, I think logistically the best second line, so we can get as many people as we can treated.
And practically speaking, we're doing the exact same thing. It's also worth mentioning we have another agent available, molnupiravir. That's another oral agent, so it is an option. And again, starting something soon is always better than starting nothing. But with molnupiravir, some concerns about its efficacy overall compared to ritonavir-boosted nirmatrelvir, and then also some safety concerns and some warnings regarding folks of reproductive age that can really limit its use. And so, therefore, it's not as recommended by those NIH guidelines. John Paul, this was a great discussion. Thank you very much for taking the time to speak with me today.
Great. Thank you, Chuck. Have a good one.
All right. Thanks to our audience as well. Hopefully you found this informative and beneficial to your practice. We really appreciate you taking the time. Stay safe.
Earn CME by clicking the link for credit. And be sure to check out the other podcast episodes in the library.